Yo, U.S. healthcare system, burnout, racism, gun violence. Episode 45 with Dr. Nii Darko. Let's go, baby.
Welcome to Solving Healthcare. I'm Kwadwo Karamantang. I'm an ICU and palliative care physician here in Ottawa and the founder of Resource Optimization Network. We are on a mission to transform healthcare in Canada. I'm going to talk with physicians, nurses, administrators, patients and their families because inefficiencies, overwork, and overcrowding affects us all. I believe it's time for a better healthcare system that's more cost-effective, dignified, and just for everyone involved.
People, can you believe we are on episode 45? It is crazy. We have over 50 episodes when you include the bonus episodes, and we have been hustling. So if you believe in the show, if it's done anything for you, share it, subscribe, leave a 5-star rating. It'd be much appreciated. Before jumping into it, I want to thank our new team member, Mark Holmes. He's helping out with editing some of the shows. He's done a fantastic job so far. Mark, thank you so much for joining the team. You are a prince. I want to thank our sponsor, the Better Together Project, Haley Harlock, Queen Bee. She is organizing on July 9th an event where essentially it's a virtual event that supports spouses of healthcare providers. And they got some great speakers, including I just committed to doing this, which I'm really excited of doing. I'll be showing up. My wife will be showing up. Use the promo code Solving Healthcare and you'll get 10% off sign-up fees. It'll be worthwhile. So yeah, thanks Haley for the support. All right, let me tell you about today's guest and episode. It's with Dr. Nii Darko. This episode actually was recorded December of 2019, and I've been waiting for the right moment to get this out to the world, but I couldn't think of a better moment than now. This guy, I love him. He hosts a podcast called Docs Outside the Box, and it's just a nice creative show where they talk about ways for docs to thrive, whether it's through business, whether it's through other outlets, and it's a very successful podcast, and he's a great host. I actually went on the show yesterday, which is June 21st, and it was a fun episode to do. A lot of laughs and a lot of emotion, so there'll be links to that to the show notes, but yeah, you guys should check that out. We're going to do a live this week too. But let me tell you about Nii. He's a father, he's a podcaster, he's a trauma surgeon, and both our parents are from Ghana. We're both first generation North Americans, if you will. So yeah, we have a lot in common and a lot to say. In this episode, we talk about physician burnout. We talk about the differences between Canadian and U.S. healthcare. We talk about race outcomes, how your race can impact your health outcomes. We talk about gun violence. We cover a lot of topics, and it's certainly entertaining, and it was certainly fun to do. This guy's amazing. So I hope you enjoy this episode. And without further ado, Dr. Nii Darko. Dr. Nii Darko.
Hey, Dr. Kwadwo.
Welcome to the show. I feel like I'm interviewing a bit of a celebrity in my mind because I've been listening to your podcast for the last little while, and you throw down, my friend.
Well, thank you. Thank you very much. That means a lot coming from a fellow podcaster.
Yeah, no, I really appreciate you doing this. So as a trauma surgeon that works in the U.S., that has seen a lot, has been how many years of practice now are you?
I've been out close to 7 years now, so pretty much now, almost so like a veteran now.
Yeah, you're a vet. And in terms of your perspective, where do you see the problems in your healthcare system as a U.S. citizen, as a trauma surgeon? What needs fixing?
That's a loaded question, man. And as a trauma surgeon, it's funny I use that wording, but it literally is a loaded question. So if you look at it from two perspectives, right? There's the what the healthcare system looks like for a physician, a trauma surgeon, and then what the healthcare system looks like from a patient standpoint also. From a trauma surgeon standpoint, it's it's a tough question to ask, right? Because when you look at it, the key questions are, one, do you have the resources to take care of people in the way that you feel like you need to take care of people in the standard of care? The answer to that is
Mm-hmm.
yes, right? But the more deeper question though is this sustainable from a physician standpoint, right? So you spend a lot of hours in the hospital, you see a lot of patients, and oftentimes there's just one trauma surgeon or maybe two trauma surgeons taking care of people. So the big thing that trauma surgeons, or the big thing that physicians in general are suffering through, and I wouldn't say, I can't tell you the numbers, but there's a good amount of physicians who are suffering through this, is almost burnout, basically physician burnout,
Mm-hmm.
where they feel like, the stakes are very high. You're taking care of people who are very sick, and they do great work. They take care of the people who they can save, and the people who you cannot, you still provide amazing care. But oftentimes,
Mm-hmm.
at what expense, right? What expense does that mean from a
Mm-hmm.
personal standpoint for a physician? What it does from your general health standpoint, from your mental health standpoint, from a family stability, missing a whole bunch of different things. What does that mean? And I think, this new type of thought process of thinking about what's really good, not only for the patient, but also how can we make things sustainable for the physician? This is something that's relatively new. It started,
Mm-hmm.
I'd say maybe 15 years ago, maybe even sooner than that, where we're really starting to look at the physician from a standpoint of not just being a commodity, but actually someone who, is not a robot, but someone who has feelings, someone who gets tired, someone who can call for help. So that's kind of where the healthcare system is from a physician standpoint, is providing great care, having the resources which we have, but also at the same time, it's a double-edged sword, right? Like, how can the
Mm-hmm.
physician be as happy as possible? Because we all know happy physicians, take care of patients really well. From a patient standpoint,
Mm-hmm.
the really interesting thing is from a healthcare standpoint and how we're taking care of people, it's interesting, right? Because we spend the most amount of money on healthcare, right? Per capita, per patient, out of
Mm-hmm.
any other country in the world. But I think, I can't remember the last statistics, but I think we're somewhere in the 30s in terms of outcome, or
Right.
patient outcome, and so forth. So there's a disconnect there, like in terms of how much we're spending versus how well patients do. Oftentimes people send their patients here to get the latest and the greatest, but there's an adage, and my wife says this because she studied work under one of the previous surgeon generals, Dr.
Mm-hmm.
David Satcher. But one of the things that she always says that she learned getting her a fellowship in sexual health and public health was, people oftentimes say, like, listen, if you get sick, come to the United States. If you want to stay healthy, go to
Right.
another country. You know,
Interesting.
it's very interesting. So I think the other thing too is just the cost of healthcare is extremely expensive here, very expensive.
Yeah, that's actually, so you've touched on quite a few things. That maybe my first comment in terms of burnout, like obviously for sure it's a real thing. We're seeing more docs experiencing that, and speaking of it, is it getting better? You know what I'm saying? Like, is it truly getting better? Despite having the more conversations about it, despite having more awareness about the issue, like in your life, do you feel like we're making some improvements?
I think the biggest improvement that we're making is being able to literally have this conversation, right? Like, I'm
Mm,
not sure how old you are. You sound pretty young, but it's possible. Like, huh?
42.
Okay, so I'm 41, but probably maybe the generation behind us, before us, having this type of conversation between two doctors, they would have just laughed at you, right? Like,
Right.
burnout, what is that? What's physician burnout? Like, doctors are to come to the hospital, work, and that's it. And they come home. So
Mm,
I think that now that we can have this conversation openly on a podcast, you're in Canada, I'm in the United States, the fact that we can have this type of conversation, I think, is one of the biggest things that's for the better, right? That means that you can literally be more aware of the situation. That means that now people don't have to go into hiding. People don't have to, keep it to themselves. When you have medical
mhm,
students and maybe even, medical residents, you can let them know that it's amazing to have this knowledge. It's amazing to take care of patients, but also at the same time, you got to learn to love yourself also. That's just as important. So I think from a 30,000
mhm.
foot view, yes, that is one of the best things, is just the awareness, the fact that this is out there. Now you have
Absolutely.
coaches who are popping up, who are helping physicians really handle this situation. There are podcasts like yours and mine, blogs, there's YouTube videos. There are a lot more outlets
Mm-hmm.
for physicians to really, connect with their feelings and really understand what's going on with them. Has it gotten better overall? That's really tough to say. I think, one of the
Mm.
things that I'm really impressed about is the millennial generation, that generation that we just missed, that 1981, if you're born in 81 or 80, that group up until probably the
Yeah,
age of, maybe 37, 38, they're bosses with what they want, right? Like they want to be able to take care of patients, but
right.
they're very clear with saying that lifestyle is very important to them also. And they've kind of led the way through this whole process of kind of demystifying what it's like to be a physician and demystifying being fulfilled as opposed to being successful. So I
Right.
think, to answer your question, I don't know if it's gotten better, but I do know that we're willing to talk about it more, which means we're well on our way to making it better.
Yeah, I mean, personally, I do think it's getting better because of the reasons you stated, and people are willing to be more vulnerable and be more vocal about their concerns and the issues that they see. And I got to say that it is inspiring seeing like quote unquote millennials step up and be like, "Yo, man, this is BS. We got to like slow this stuff down." Like I could give you examples of, I went through internal medicine, and it would be normal to be in hospital for 28 to 30 hours, maybe get 1 or 2 hours of sleep. And these kids now are saying, no, we're doing shift
Yeah.
work, man. We're not doing more than 18 hours. They come up with their own system. They give better care. They're more fresh. You know what I'm saying? And everybody wins. And that came from them. It wasn't coming from the top. It wasn't coming from, you know, their program director or whomever. It was initiative coming from the kids. And now it's tolerable. They're fresh. They're ready to go when it comes down to their shifts. And it's a beautiful
Oh
thing.
yeah.
But one thing I did want to ask you, and forgive me if this is too personal, what have you done to kind of mitigate some of this burnout? Because, trauma surgery, I could speak to the trauma surgeons here. Like we get obviously less GSWs and stuff, but it's still high volume because of motor vehicle accidents and so forth. But regardless, the hours are horrible. There's a high demand for you. What have you made any changes in your life to try and either mitigate or reduce the amount of burnout?
Oh, absolutely. So yeah, that's a really good question because, within the realm of trauma surgery, the notion is you put your head down, you work hard and you basically kind of just tax yourself. And that's just kind of the mantra. It's high, a lot of chaos, a lot of energy, a lot of stress. That's kind of what we live for. But, that type of lifestyle has an effect on you. It has an effect on you from a health wise, from a stress wise, has an effect on, your family life and your home life also. So one of the things that I'm really excited about, really happy about is that trauma surgery has slowly, but it's starting to adopt the process of having shift work in the realm. And that if I admit a patient, it's not just my patient, it's also my patient and then the rest of my partner's patients. So that, if I do surgery on a patient
Mm-hmm.
at 4 o'clock in the morning, that, if something happens at, 2 in the afternoon, I'm not expected to kind of wake up out of bed and go back and do something. My partners can take over. That's been one of the biggest, I think,
Mm-hmm.
one of the biggest things that trauma
Mm-hmm.
surgery has kind of brought into its repertoire is the ability
Mm-hmm.
to do shift work. So, doing a 24-hour shift or maybe even longer in the old days,
Wow.
really wasn't a 24-hour shift, right? Because if someone came in at 4 in the morning or 3 in the morning, and then the earliest that you can get into the operating room was, maybe 7 o'clock or 9 o'clock or 10 o'clock the next morning, well, that was your case. And now you're not doing a
Mm-hmm.
24-hour shift, you're doing a 36-hour shift. And then you get a short period of time to sleep, and then you come back and you do it again. That's not healthy, right? That's
Mm-hmm.
not good for the doctor. That's not good for the patient. So for me, the biggest thing is just making sure that I'm embracing programs,
Mm-hmm.
embracing areas that embrace this type of mentality where we all are taking care of the patient. It's all of our patients. And if my partner needs help or if my partner needs to go get go sleep, then I can cover for him or I can cover for her. The other thing too is just
Mm.
me was starting these conversations, having these conversations, with other doctors, having the podcast, Docs Outside the Box, finding out what the lay of the land is. I
Oh,
just kind of
man.
felt like I was on an island when I first started working on my own I really enjoy what I do, but also at the same time, there are these other things that I really would love to explore. Medical humanitarian work, interviewing other doctors about the cool things that they're doing. So just being I mean, look, there's no such thing as balance, right? People say that, but is there really balance, right? Let's be honest, right? But trying
Mhm.
to be as balanced as possible, being a good surgeon, being a good family man for me,
Mhm.
and also at the same time leaving a legacy of, making it a lot
Mhm.
easier for people to have these type of conversations, electronically or whatever way, for me is like the best way for me to combat, stress, is the best way for me to combat burnout, because I feel like now, like I have like what's the word? I feel like I have like I have direction, I have focus, and that eventually I'll leave this earth with really a legacy.
No, that's beautiful. Because I think if you think about how much of an influence this could have, you know, how many people listen to podcasts now? I just watched one of your YouTube videos on the power of podcasting, which we could talk about also. But listening to trained professionals talk about being vulnerable, talk about their concerns, talking about how they can reduce the amount of burnout and talk to others about it, man, like if you're an upcoming wannabe trauma surgeon, orthopedic surgeon, intensivist, hearing that, you put value to it, and you realize that you can be a human being. And I don't know, I applaud everyone, that are doing efforts like this to educate the public, educate their fellow trainees and physicians, because I think at the end of the day, we'll provide better care. You know what I mean? You being on your 36th hour, I'm sorry, it's not the same as when you're coming in 4 hours into a shift. And I think, when you talk about leaving a legacy, that is exactly it. It's so important.
Yeah, I agree with you there. Yeah, you're right.
So I gotta ask, as Canadians, when we hear or see the news about U.S. healthcare, we get the sense that it's quite differential. It's, if you don't have quality insurance, you might get subpar care, or if you don't have insurance at all, you might not get the care that you need, and you'll be slapped with a huge bill that makes you put out a second mortgage on your house or whatnot. I want to get a sense from you. Is this fake news? Is this what you see in your day-to-day life? What's your perspective on this?
So it's a good question, because there's a lot of fake news. There's a lot of I hate to use that term, but there's a lot of news out there that's just not reliable. And so yeah, there's basically like three types of situations that occur in the United States. There's the you work for your company that you've been working for, and they give you health insurance, right? That's private health insurance. So anything that occurs, for the most part, you know that you're going to be covered up to a certain amount, and that's health insurance that comes along with you being employed by your job. And then the second one is a government funded type of health insurance. Those are for people who are 65 and older. That's called Medicare. And then there's also coverage from the government for people who don't make a certain amount of money, that are considered, below the poverty line. There's some coverage for children, as well as people who have certain coverages or certain medical conditions like, end stage renal disease and other things where they actually have government funded healthcare. So between those two, those are the ways in which, for the most part, the majority of Americans have healthcare. And then there's a large portion of people who just don't have any healthcare at all. And that's where you start to get the issues of, if you don't have any healthcare, one, can you be seen by someone? Two, if you are seen by someone, and you get care, how are you going to be able to afford it? Are you going to have to, like you said, take out those second mortgages if you can? How are you going to be able to make those payments? That's the part that's really scary. Now, the Affordable Care Act, which is something that probably your audience probably knows, maybe by the nomenclature of Obamacare, it tried to fix that,
Mm.
which basically required everyone in the United States to have health care in some form or fashion. And it basically got rid of some really cheap plans and got some plans that made sure that it provided really good care for everyone. But there's a lot of political theater. There's a lot of political fodder. There's a lot of money in our government here in the United States from all external sources. And as a result, some of those things have been kind of pulled back. So the way how I look at it as the way how it's affected me is if I'm a physician or if I'm a business person who wants to run their own business, years before it was really difficult to do that, because one of the things that you always thought about is, well, look, I have this great idea. I want us to have this startup, or I want to, be in business for myself. But the one biggest thing that held a lot of people back was, well, I can't afford healthcare. I can't afford to buy healthcare on my own. Right.
Mm.
And what the Affordable Care Act did is it made it a lot more affordable for people like that, people who work for themselves, people who may even have a pre-existing condition, diabetes, or, whatever it may be, that normally would end up paying a really high rate on their own. It'll allow them to really buy affordable health insurance. So yeah, a lot of the things that you see on TV is true, unfortunately.
Mm.
If you are employed, then you have health insurance. That's great. If you're not employed and you're not under Medicare or Medicaid, then you're kind of left to fend for yourself for the most part. There's some programs here and there to help you, but it's still a situation where people, can still go bankrupt, or people, if you get cancer, that it can, end up like losing your home. Those are situations that are still out there.
And is this what you're seeing? You know what I mean? In your day-to-day life, like at your hospital, are you seeing patients that are having to make these decisions, whether I'm going to get, for example, in that cancer example, am I going to get chemo, yes or no, based on the fact that I don't think I could afford it, or I will do chemo and just realizing that I have to find finances somehow.
Oh yeah, absolutely. I mean, you see
Oh my
patients
God.
make these type of decisions. They play this game of balancing, one thing, like how am I going to eat, or where am I going to live, versus do I really need this healthcare that the physician is telling me about? I did my training, my initial residency training in general surgery. I did that at a hospital called Grady Memorial Hospital in Atlanta, Georgia.
Mm.
And it's a large, 1,100 bed hospital, which treats mostly patients who are indigent, which means they don't have healthcare coverage. So in trauma, how that related is, you see someone who gets into a car accident, or someone who gets, who has some type of injury, you take care of them, and then you tell them that you may need further things, like you may need rehab, you may need rehab for your brain injury, or rehab for your back injury, or rehab to kind of get you back to doing what you normally did, back to your job. And then they say literally, like, I can't afford this.
Mm.
And depending on what kind of injury they have, you have people who can't walk, maybe for several weeks, mainly because they have really bad fractures to both their legs, or some people have injuries to all four extremities. And in order to get into a rehab or to get into a nursing home, you need a certain type of coverage, and we've had people just linger in the hospital until they're able to, finally get some type of aid to help them. But, they're already behind the eight ball. Or
Mm.
some people, they just say, look, just send me home. And you look at it and you're like, well, who's going to take care of you? Because you either need 24-hour coverage or some type of supervision. And not to mention the fact that they probably won't ever be able to get back to their job, because they don't have access to get them to, rehab or some type of ancillary service. So I see that a lot. I saw that a lot when I was in Grady. And
Wow.
but when I moved to a different hospital, and several different hospitals, I saw that less and less, mainly because most of the people that I saw, I wasn't in those type of hospital that treats indigent people, but mainly people who are, suffering from blunt trauma, which is mainly the geriatric population who, they have Medicare, or if people were in car accidents, they had car insurance. So that took over there. But you still see people who don't have anything whatsoever. And the same type of situation. They linger in the hospital for an extended period of time. Like the hospital becomes a rehab unit, so to speak,
Mm.
which, you and I both know, for the most part, is not the best place to do rehab.
Exactly.
Or unfortunately, you send them home and they, just definitely get suboptimal care there.
Wow. No, because like, I mean, the stuff that you mentioned too, that's the stuff that matters, right? Like when you have a significant injury and you want to get back to your baseline, you want to become a functional human being, you need that rehabilitation. You need that physiotherapy. That's the stuff that matters. And then, they're saying you can't afford that stuff. It's just, it's
sad. And
Mm.
because I get this question I used to get this question all the time when I was training, even now, because of our provincial governments have made some dramatic pay cuts to physicians and stuff. They say, would you ever go down to the States? And this is one of my biggest fears, is hearing these stories, like looking some cat in the eye and saying, you know what, I know you can't afford it. And we either got to like make you poor by providing this care, or give you suboptimal care because of your financial circumstances. It's very different than what we deal with in Canada. So it's like almost like my mind is blown when I hear these stories. You know what I'm saying?
So what happens in those situations? Because I'm sure you've seen those situations. Like, for example, like when you have someone, well, everybody has insurance, right? So how does that work out?
Exactly.
Like if someone breaks their legs and they can't get back to work and they have to go to rehab, is it always just a smooth process? They get to the next stage?
Straight up. Let me tell you, in Canada, there's universal health care. So yes, you are covered for all the basic services, like stuff like drugs, some equipment aren't covered, physiotherapy is not covered out of hospital, stuff like that, vision, that's not covered. But you come in as a trauma patient, even if you don't have a health card for some reason. So you come in from the streets, okay? You're getting everything you need to survive. You're getting the rehab in hospital. You're getting the drugs that you need. You get sent to a center a rehab center that is still within, that is covered within our Healthcare Act. And we get you better, regardless of where what your financial situation is. And so different provinces pay different premiums to cover that, but it's usually fairly low. And even, to be honest with you, even if you don't pay it, no one's kicking you out the door. We're
Okay.
Canadians.
Gotcha. I understand. I understand.
but it's interesting. So like it ain't fake news, basically, is what I'm hearing, is, when it comes to the US and its current state when it comes to healthcare.
Yeah, it's a problem. Let's just leave it to you like that. And it's something that we still need a lot of work in. And the biggest thing from my perspective is just like the political games that people play,
Mm,
that, our politicians play. It's really unfortunate. It's really unfortunate because, and health insurance has a huge lobby in the government. Hospitals have a huge lobby. Doctors not as much, but they still have a lobby. So
mm.
it's like everybody's self-interest, unfortunately, and it doesn't produce a really good system, I don't think, overall.
And this might be a loaded question, but do you see solutions? Like if you were king for a day or a month, whatever.
That's a good question. I'll tell you why. Because, oftentimes you hear, well, if you let the doctors handle everything, then, things will be better. But is that really true? Like, because you think about it, most doctors don't know how to, their finances aren't the greatest. A lot of
Hmm.
people say doctors get paid, at least in the United States, doctors get paid a certain amount, but oftentimes doctors aren't the most wealthiest people, right? Because,
Right.
some of the decisions that they make, aren't the smartest. But in terms of like doing the, pro forma, or doing, the X's and O's, we don't get any training in that.
Right.
Right. So, and then how do you manage all of these different things? We don't really get much training in that. So I don't know necessarily, what the solution is. And, people just saying, well, just have more doctors in there. I think that could help. But like literally having doctors as leaders in this, I don't know if that's the answer. I think one of the
Yeah.
best things that we have to do, number one, is we got to stop the amount of lobbying that's occurring to
Mm,
politicians, because ultimately what's going on is that's the part where is the huge problem. You have people who don't really know much about healthcare or much about how medicine in general is practiced, yet they're making all the decisions based off of, lobbying, and that's a problem. I think that's a big, big problem.
I think that is a huge area that of like I think that's where the real solution is. Like there's I mean we see the power of lobbying when you see the NRA stuff.
Oh
Like
my goodness, yeah.
I mean I don't know what your political alliance is. I don't know if you're I mean, it might be too personal with the guns issue, but when we see this stuff, like, let me tell you something. This might be a little bit of like I'm going off the rails a bit here. When I saw kids being shot up in Connecticut, okay, you knew, and then nothing really changed. You knew nothing's gonna change.
Oh yeah,
Kids, man,
absolutely.
6-year-old kids. Like, how old are your kids?
My kids are 2 and 3 months.
Yeah.
Yeah,
Oh,
absolutely.
congratulations, the
Thank you.
young.
Thank you.
Yeah, and I just, to me, if the kids can't change their mind about this shit, nothing will. And
Yeah.
it really shows you the power of the lobbyists and the NRA and so forth. I mean, you live that world too, from a trauma side. You know what I mean? Like, we do not even come close to seeing the amount of gunshot wounds as you guys do. Like, I work in the ICU. We'll get at our trauma center, we'll get maybe 6 a year.
Yeah.
Like, in the ICU anyway, maybe some of the trauma unit will get some, but like gunshot related trauma, minimal. And we're a population of about 1 million plus. You know what I'm saying?
Yeah, it's
Crazy.
one of the proudest times that I've been to be a trauma surgeon was, I don't know if you remember, basically the NRA had basically made a statement. I forgot, there was an event that occurred last year. Some type of obviously shooting occurred, and some trauma surgeons had said something, or some physicians had said something, and the NRA basically, and I'm paraphrasing, said,
Mhm.
like, stay in your lane. Like, what do you know about all
Oh,
this
yeah,
stuff?
yeah, yeah, yeah.
And you're just like, wait, what do you mean? What do I know about this? So literally, doctors, surgeons got, really fired up and started taking pictures of, like, bloodied, scrubs and bloodied shoes and bloodied,
Mm.
operating room floors, and saying, what do you mean I don't know what I'm talking about and I should stay in my lane? This is my lane. Like, this is right in my lane. And for, like I said, I don't know. I can only speak on, since I've been practicing and, in med school and so forth. But like, that was one of the first times that I saw physicians really take to social media and
Mm.
really use one voice and say, look, this is what is affecting not only patients, but it affects us, it affects our system. We need to do something to change, as opposed to being, like, these bystanders in this situation. Well, I don't know. I mean, I just got to follow whatever the politicians say. And it's like, no, like, we have a word, we have a powerful voice. Let's use it. We have
Mm.
social media. It doesn't cost anything. You don't have to lobby anybody. Just get on social media and let people know what's going on. And
Mhm.
I was very, very proud, to be a trauma surgeon, because, we've been leading this thing, but we haven't been leading it strong enough.
Mm.
And there are trauma surgeons throughout the country who are stepping up more. You have the Dr. Brian Williams. You have, just trauma surgeons throughout the country who are speaking out more about this, and, letting people know that this is what I see on a daily basis and nothing has changed. And you're right. I mean, the first part is, once, I think even before the children, which was an extremely sad thing, is I remember I was just like, oh, well, probably what will happen is if a congressperson got shot, then it would
Wow.
change everything. Right. But that occurred, nothing happened. Right.
Mhm.
Then another congressperson got shot. Right. At the baseball game. I don't know if you remember
Oh,
that. That
yeah,
was a
yeah.
couple years
Yeah,
ago.
yeah.
And, and then you have Sandy Hook, and nothing happened. So it's just like this, like you said, it's really the power of lobbying. It's the power of, people who really feel very strongly about the Second Amendment, and how votes work and how power works. It's
Mm.
it's very, very, very it's very difficult,
Yeah.
as even someone like me who's raising 2 boys now, I'm
Mhm.
very fearful about those things. Even as myself, I'm very fearful about that.
Yeah, I gotta it's gotta be troubling in the sense that, like, I would feel a bit powerless, and because, like, once again, all these shootings are happening, and the people that shouldn't be shot aren't, like, no one deserves to be shot, obviously, but, like, really, kids getting shot is not changing anything. Congress people not changing anything. And, and I mean, it's got to be tough seeing that as a trauma surgeon too. Like, especially, like, I always find it's always tough seeing people that you can most relate to. So when you see young patients that are injured, young people with families, like, that's always been the toughest for me as a ICU doc or a palliative care doc. And, you get a 20-something-year-old kid that gets shot up, and that they had their whole life in front of them. They may or may not have had a chance to have a family. It's It just breaks my heart when
Oh,
it's something that.
I'll take it a step further. I mean, as an African American male,
Mm,
I remember doing some internship work, as a fourth year at Cook County Hospital in Chicago, which is a gunshot. A lot of gunshots happen there. A lot of people are dying there. A lot of that type of violence is occurring there. And you just see what happens on a day in and night in basis of, African American men, men of darker hue, men, who are black and brown coming through. And you just, as a physician, or even as at that point as a medical student, you're just like, what is going on here, right?
mm,
You feel helpless there. These people literally look just like me. These are, depending on circumstances, could be cousins, could be, whoever it may be. It affects you,
mm,
and like I said, if we take it back to what I said earlier in the show, we're not robots, right? Like we're trained to be technicians, and we're trained to take the emotion out of it. But that's really very powerful and sobering, scene to see this night in and night out, and
mhm,
to know that what can you do. But one of the things that I feel really really hopeful about is, you have, men and you have women who are coming from these neighborhoods who are able to get out, and they're coming back to help. So you
mhm,
have Dr. Gore, who is an emergency room physician in New York, who started the Kings Against Violence initiative. He grew up in Brooklyn, New York, and then trained at Cook County and Chicago, both high crime areas. And now he started a youth intervention violence program in Brooklyn, called
mhm.
Kavi. And he was really close to winning one of the CNN Heroes thing last year. So if anybody's interested, go ahead and check that out. There's, Dr. Brian Williams, Dr. Ken Wilson, who are doing great work at University of Chicago. Dr. Ken Wilson is from Baltimore, but then did his training at in Atlanta, Georgia, and now is doing work at University of Chicago. So that's the part that for me, I'm just like, okay, I'm feeling really promising about this, because we're not just victims in our communities. We're coming back. We're doing work, but there's even so much that we can do from that standpoint, also, right?
Mhm,
Like you need, like you said, like you need like a top down approach, right? Because a lot of
mhm.
this stuff is rooted in, one, how we treat our communities, how funding occurs in communities, how we police our communities, things like redlining. I don't know if you guys are familiar with
What's
that.
that?
Redlining is basically, it's an old policy, that was very, very subtle, but basically based off of the people who lived in certain neighborhoods. Certain mortgages and certain resources to a city were given to that town, or given to that portion of town, or taken away from that portion of town.
Hmm.
And as a result, you have houses that were great houses, or, houses that structurally are great, but just nobody can get a mortgage there. Or maybe the property taxes are too high, or maybe the schooling system is not that great. So as a
Mm,
result, you just have this cycle that occurs in these neighborhoods. And as a result, being able to get out of that community is that much more difficult. It's more than
mhm.
just studying. It's, can I get home safely?
Yeah.
Do I have the schooling? Is my teachers have enough funding? And not to go down this whole rabbit hole, but that's just kind of those things that, you think about, as a physician, particularly in trauma areas, particularly in areas that get a lot of gunshot wounds. It's more than just violence. It's a whole, multiple dimension, multi-dimensional thing that occurs here.
Yeah, I mean, if I've learned anything by doing this show over the last little while is we often are not giving our kids, we're giving them a recipe to fail quite often. If they're growing up in an area that is not safe, they got to worry about their ability to walk to school. They have teachers that are maybe not at the same standards as other places. Their circle of friends are might be into some drugs or violence. Like, it's hard to overcome that.
Yes.
I recently I interviewed one of our truly angelic physicians, Jeff Turnbull, and he does inner city health, and it really does amazing work. And when you get to hear the stories of what all these people have gone through, it is no wonder they're homeless or battling drugs and alcohol. And it might be motherly saying this, but it really emphasized the value of investing in our community, providing a safe environment for our kids, and really trying to provide them a way to be able to thrive. You know what I'm saying?
Yeah,
Um,
I agree with you there. And I think
yeah.
we as physicians, like, we have to be the protectors of people who are the most vulnerable, right?
Mm,
It's not just like you said, like just taking care of people and then that's it. See you there later. It's, literally like thinking about how they're going to be able to pay for this medication, how they're going to be able to get to rehab. If, they suffer multiple rib fractures and I decide to do this procedure, how much is it really going to cost them? Like
Hmm.
all these different things you have to think about. It's really difficult. It's really
That's
difficult.
that's got to be so challenging. Like it's just like as you described. Like just to give an example for the non-medical folks. So like in my world, if a trauma patient that has multiple rib fractures, you think that's it's just rib fractures. What's the big deal? But you as a result, you might have an inability to cough or clear your secretions. You get a pneumonia. You end up being on a ventilator because you can't breathe and clear that secretions and complications there afterwards. And so there's some procedures where you could, give some local anesthetics on the ribs. I don't know how expensive that is in the U.S. system, but once again, these things in Canada, we push for, and that procedure could prevent all that kind of downstream effects from what I was just describing. But thinking to yourself, should I be offering this knowing that the paycheck is that they have to pay out of pocket? Like, how heavy is that shit? You know what I'm
It's real.
saying?
It's crazy. It's
Oh,
crazy. Yeah, it's crazy. And
I
then you start to realize, like, did I really help this person, or did I make it it's really tough. It's really difficult. But it's just, yeah.
yeah, no, because like there's enough decisions you got to make. You know what I mean in terms of optimal care. Like medicine isn't always black and white. There's multiple approaches, and to have that as an additional factor into trying to do what's best for the patient. Oh my God. That just must be so difficult.
Oh yeah, I agree with you. Yeah.
Oh man. So I got a couple other questions for you. Once again, we talked about offline. We talked about being, you don't run across too many Ghanians or African American clinicians. And to give you a bit of background too, I grew up in Edmonton, Alberta. My nickname, this, I don't know if I'm going to keep this. But my nickname was Black People because wherever I went, I was representing Black people. There was no brothers anywhere. You know what I mean?
Yeah, 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 yeah,
And
yeah.
I played hockey. And
Oh
recently,
man, you're a
yeah,
unicorn.
yeah, exactly, a unicorn, coconut, whatever. But recently, in the news, there was incidents that came out where coaching staff were using racial slurs towards black hockey players, and it
I
was
heard
funny.
about this.
I
Yeah.
got a bunch of messages saying like, how what was your experience like playing hockey growing up in Edmonton and stuff, and luckily my coaches were great. I never had any experience like that, but certainly on the ice, it was horrible. Every name that you could think of, I got called that, and I've always wanted to ask this because I don't get this situation and that often. From your experience as an African American physician, was there struggles? Was there discrimination? Was it well received? Like, what was your experience like?
It's I have to be really honest. Like I can't say any situation where I've had overt racism or overt discrimination at me. Over the past 6 years, I've been working in a rural portion of Pennsylvania, and I have to be very honest. Like people have been very sweet to me.
Mm,
The one thing that I have to look at it as is, when I walk into a room, obviously there's not many African Americans who live in this area. There's not many African American doctors, obviously, more so. But I've never had anybody overtly say, "I don't want you," or maybe one time. And actually, that wasn't even in Pennsylvania. That was in another state.
mm,
But you look at it as an opportunity to teach people. I look at it as an opportunity to teach people. I look at it as an opportunity to just let them know that, medicine is practiced in so many different forms and factors. The standard of care is the same. What I do, is just that, I'm African American and this is what I do.
mm-hmm,
But I'm sure that there are more situations where people can definitely attest to there being some type of, behavior based off of race or behavior based off of some type of discriminatory or bias, bigoted action and stuff. So, but I truly can say, and I'm really blessed to say that I can't really think of a moment where that's been overt to me. Now, before that though, growing up, I grew up in New York City. My parents were immigrants, but it was very, oftentimes, I don't know if your listeners are understand this, but there's there's this experience of being an immigrant, and then there's an experience of, being in the United States, which is, like your parents are first generation. And then there's a certain language that's spoken in the house. There's a certain culture that's in the house. And then there's, when you leave the house, the type of culture also that you're quote unquote need to assimilate into also. So for me, being raised as African in my house and then being raised as the African American, sometimes those are two different things, right? Like you're African, but also at the same time, how you're looked upon and how people think about you as an African American, like you can't really separate those two. So I was my parents made sure I was very aware that, just the rules are very different oftentimes for people like me in the United States, how people perceive me, how, my interactions oftentimes with authority, with police, what have you. I have to be very careful about those things. I remember having the quote unquote talk. I don't know if people are familiar with that, but, you get the talk, which is, when you talk to a police officer, it's very yes, sir, no, sir. There's never any back talk. It's, you just do whatever you need to do to live in order to get back home to mom and dad. And then you let us kind of handle those type of situations, right? Like these type of conversations don't happen, I doubt, in other types of homes, right? In white homes, right? But in a black home, I'm going to have that conversation with my kid, no doubt, right? Is like these type of conversations occur. So I was very aware at a very young age growing up in Queens, New York. I was very aware of like the differences that occur and how we're treated and so forth. But as, became a medical student and resident, I even did, my medical school out in Kansas City, Missouri, and I did a bunch of my rotations out in the Midwest. People were very sweet to me. And people were very, very, very sweet to me. And sweet to my wife at the time. Well, she was my girlfriend at the time. She's from Haiti. So, oftentimes we were in very rural areas of Missouri or, Kansas and so forth. And people were very, very sweet to us. So from a medical standpoint, I have not seen it.
Oh, well, I'm glad to hear that. I think at a personal level, like it's few and far between, but certainly, snide comments. I've experienced it all, but fortunately it's been rare,
Absolutely.
But it's, I can't help to get emotional though. Anytime I hear about the quote unquote, the talk,
it's like you're literally taking the innocence away from your children.
Yeah.
And
and I'll be honest with you, we're in Ottawa. It's not the same, but it's more like my kids are mixed race, but still, if we're traveling to the States, like you gotta be careful. Like I'll give you an example. We were in Tampa Bay, Florida, and we're having a good time with my boys, and they're about to jaywalk, like go across the street, jaywalk to get to another bar or whatever. And I'm like, I ain't jaywalking shit. You know what I'm saying? I ain't there's zero chances here down in Florida that I'm crossing the street when I'm not supposed to. I'll see you guys in about 3 minutes. So it's just it's hard to hear that, and hopefully that situation gets.
Yeah, it's one of the things that I think is a stain in the United States, and the United States is not alone. But it's one of those things where, like, we are, for example, like I had a patient in one of my previous jobs who, this is a rural portion of the United States, and he came in with a gun. Like he was in a car accident and came in with a gun. Like a motor vehicle accident. He just happened to have a gun. I think he had a conceal and carry license. So he's completely legal and so forth. The problem though is, and I didn't see him initially, the problem is that one of my partners, when you're evaluating someone, you take all their clothes off, you're evaluating them and so forth, but the gun fell out. And thankfully it didn't go off. Nobody got injured or anything like that. But I remember my partner saying to me, he's like, listen, like I'm going home, but can you have this conversation with this guy? And say, look, man, you can't. And I'm like, yeah, no, I'm not having that conversation with this guy. Like, that's on you. You know what I'm saying? My partner is white. And I was like, yeah, I'm not having that conversation. And he was like, well, why not? I was like, well, just because I don't feel comfortable having that conversation. And, I finally I'm like, look, me as a young black male, black physician, although, there's a certain, authority that comes along with that. Like, I'm not having that conversation with that. I don't feel comfortable having that conversation with a white male who has this situation. Say, you need to let me know X, Y, and Z. Because I just think that it's just different, you know?
Yeah.
It's just different, and that's the best way I could really explain like the differences that occur, right? He could have that conversation, but I don't think necessarily I could have. Now, obviously I can have that conversation, if you know what I mean. Like I can
Right.
have that conversation. The question is, you start to think about, well, what are the consequences of these type of things, right?
Mm-hmm.
So
Mm-hmm.
that's the part that I think, you start to realize like when you have that talk with your kids, you're just like, man, like you take away their innocence, so to speak, right?
Mm-hmm.
And then, you kind of, I don't know how to explain, but it's like it's almost like their light can't shine as brightly as you want it to shine because they have to be concerned about X or they have to be concerned about Y. It's just one of those things that you just get a little bit concerned about. But I think we're moving in the right direction. I
Yeah,
think
I think
provided
that's
we all
fair.
can have these type of conversations more often without people, taking it too personal and just being open and honest with each other, having a conversation, not
Mm-hmm.
being too politically correct about things, right? Because
Yeah,
sometimes being too politically correct oftentimes makes sure that people don't talk, right?
exactly.
you know
Exactly.
so just being able to have these conversations like what we're having, which we 10-15 years ago before podcasting we would never have been able to have this conversation, right?
Exactly. And I could guarantee you, even some of the listeners they're listening now and they're like, this is a bit hard to listen to because it makes them a bit uncomfortable.
Hmm.
But it's good to hear because this is how change happens, my
Oh
friend.
yeah. Oh yeah.
So listen, what I want you, like I like to end off with on a positive note. And I want you to tell the listener a time where you were proud of what you do, where you got that feedback from whether it's a patient or a family member or administrator or something, where you were like, you know what, I belong doing trauma surgery, being a leader, being a podcaster, whatever it might be.
Well, I mean, I could give you a bunch of them, but one of them was actually recently. So one of the where I trained at in Atlanta, Georgia. So people who are not physicians, you have a chairperson who's in charge of the entire division of the medical specialty. So in my case, surgeon, there's a chairperson, and he's in charge of and making sure that the department, the rest of the other surgeons are kind of working hand in hand. But also, what this chairperson does is he makes sure that he's the final say on who gets brought in to train for residency, right? Who are the new doctors who just graduated? How are they who's going to get accepted and how they're going to train? So my chairperson, his name was Dr. William Lynn Weaver, and very, very impactful life, not only from his family life, but also from a medical standpoint. And he accepted me into his program at Morehouse School of Medicine and forever changed my life,
Mm.
and really held him in high regard. Was a bit scared of him, but very revered, and taught me a lot about not just medicine, but also taught me about a lot about medicine. Well, unfortunately, this year he passed away.
Oh.
So I had to go to his funeral. But I was working in Wisconsin, the day before, 2 days before, and my partner accepted a patient. This goes back to whoever my partner admits or takes care of is really my patient, and then vice versa and so forth.
Your
So
team.
my partner accepted a patient who went to another hospital, had some abdominal pain. They did a CT scan that showed that this patient had a hole in his intestine, something that's called diverticulitis. And there's two ways you can treat it, either with an operation, or sometimes in some of these patients, you can literally just watch them and that hole will heal. And over, a couple of weeks or so, you give them antibiotics, and then eventually maybe a month from now or 3 months from now, they'll have that portion of their colon removed and they'll be fine.
Mhm.
But in this situation, it sounded like this patient was okay based off of what I got from my partner. That wasn't the case when the patient arrived to my ED. The patient was very sick. He was elderly and looked like he couldn't breathe anymore. His blood pressure was high. His blood pressure was low. His heart rate was high. He needed to go to the operating room immediately. I took him to the operating room immediately, but right before I took him, I spoke to his wife and told her that he's very sick. And I'm not sure, how he'll do, but I'm going to do the best that we can. Took him to the operating room, and there's just literally stool and poop all over inside his abdomen. We
Mm.
found a hole, and I removed it. And there was just so much soilage in there. There's so much poop there that I literally did not feel comfortable closing him up at that point. So what you do in those situations is you literally wash out as much poop as possible. You put some plastic covering over the intestines, and you put a special type of vacuum there. And you keep the abdomen open, you keep the patient intubated or with a breathing tube, and they stay in the intensive care unit for about 24 hours to 48 hours, and then they come back. You take them
Mhm.
back to the operating room, and then you do the rest of your surgery. Well, with this guy, after I finished the first surgery, which was leaving him open, you take him back to the intensive care unit. He stays on a ventilator, he stays sedated, but he needed medication to keep his blood pressure up. And we call that vasopressors. Well, by the time I left the next morning, he was on three of those vasopressors. He was on three of those medications, which means that basically he's extremely touch and go. More than likely, he's
Mm.
probably going to die. And I spoke to the wife and I told her what I did and I told her what was needed and how he was doing and that, the prognosis was very grave and grim. Well, the next morning, literally, I got on a plane, flew down to Georgia, went to Dr. Weaver's funeral, met with some people who I hadn't seen in years, and met with his family and so forth. It was a great ceremony. By the time I flew back, this guy was still very sick. And then I actually had to go to another place, I had to leave the hospital again. By the time I came back, long story short, he was off of this medication. My partners had closed his abdomen and, he got the tube out of his mouth and he's talking, still very weak, not really eating and so forth. But the wife just gave me a huge hug, you know, she gave me a huge hug and said, "Thank you so much for what you did." And I said, "Well, I just did the first surgery, like he, got through X, Y, Z, all these different things." She's like, "No, but like, you did the best you could and he survived and stuff." And like those type of feelings, combined with what I was going through with, the death of my chairperson, you really start to think about just what we do. We're not robots, right? We're not, patients aren't just textbook cases. Like, these are real individuals, right? This is a patient who has a wife who loves him very much. He probably has children, who probably has, sons, daughters, whoever who really much care about him a lot, just the same way how, my chairperson has a family and allowed me to be in his program. And then from there, his legacy continues through me. And now I'm able to provide that type of care to my patient. Right.
Mm.
So it's like, that's why like something like that really resonated with me because it really talks about like how like it really talks to how we, this just the human element, right? That we don't get
Mm.
to talk much about in medicine, right? That human element, that spirit, that soul, that legacy, the pay it forward type of thing that, we don't really talk much about. But when you see it, you're just like, wow, was this at play? I don't know if a higher being is in play, but
Mm.
that was a moment where I felt like, wow, like, 7 years into this, I'm really meant to do this. And I was
Wow.
here for a reason. And he let me into his program for a reason. And now it's my turn to affect people based off of his teachings.
Yeah. Wow. That is that's incredible. First of all, sorry to hear about Dr. Weaver and but I love what you're saying though about making it clear that these are human beings, humanizing our patients, right? Like it's something that I hate to say we forget sometimes based on the volume of patients we're seeing, how busy we are, but hearing stories like that and the impact you could have on an individual or family, it's so powerful. And I'm glad you shared that with all of
Thank you.
us.
Thank you for helping me talk about that actually too. I didn't, you think about it, but when you talk about it with someone else or you talk about it on the podcast, it really, puts you in a different perspective, right? So I appreciate you asking that question.
No, absolutely. I want to know about your charitable work. You do work in Ghana, and
Yes.
why I am ultra envious of you is I've been telling my wife that we are long overdue to be able to give back. We're in a very fortunate situation. We have great jobs, wonderful children, and now that things are, getting your head above water with training and all that stuff, for me, I would love to give back. And you've done this 7 years into your career with a young family, and I just want to give you the opportunity to maybe speak to what you're doing in Ghana.
Yeah, thank you very much. So I work with an organization called the International Healthcare Volunteers, and it was started by Dr. Charlotta Ayers as well as Dr. James Akins. And Dr. James Akins, he's from Ghana, he's from Cape Coast, and he's a gyne oncologist. And Dr. Ayers is an OB-GYN doc. And it started roughly about 15, 16 years ago. His niece, who was in Ghana, unfortunately passed away while giving birth in Ghana, which I'm sure you know, Dr. Quadro, happens far too often
Mm.
in Ghana. The maternal death rate in Ghana when delivering is too high. So basically, he started this organization to help initially with women's health, with OB as well as with cervical cancer screening and so forth. And then over time, slowly but surely, it's increased the amount of other specialties that happened on this trip. And now we're at a point where, we have general surgery, we have pediatrics, we have, so many different specialties that occur. But for me, it's really, really as close to what I call a professional reboot as possible.
Mm.
And I oftentimes recommend for people, even if you're not in the medical field, if you have an opportunity to do some volunteer work outside of the country, or even just some volunteer work with a community that you've never really come into contact with, it can be one of the most sobering, one of the most really very sobering when you start to see what people have and what people don't have, and you
Mm.
start to compare it with what you have, and like case in point, like hernias, like having a groin hernia, a bulge in your groin, that occurs a lot in the United States and it gets fixed a lot in the United States. But in overseas in Ghana or in other countries, that can be very debilitating. Someone
Mhm.
won't be able to work, which they can't be able to feed their families. And to be able to fix this type of hernia, oftentimes in the United States, we fix it surgically, but we use a special type of mesh. It's very light, looks like almost like paper, but it's very strong. And we use that to kind of buttress the repair and make it very, very strong. Well, they don't really use that in Ghana much because it's extremely expensive. And in Ghana, oftentimes they have to pay for their own antibiotics up front. They have to get blood from their family up front. They have to pay their bills up front. So it could be it's a stark difference than how healthcare is in the United States, definitely stark than in Canada. So when I say it's as close to a professional reboot as possible, you really start to realize, what you can do, the impact that you can have in those type of communities. It really lets you know that, do I really need all of these quote unquote pain medications when I come back to the United States? It really helps you to kind of understand, what is really necessary to provide the standard of care, here in the United States. And that's why I say it's as close as a professional reboot as possible. From a personal standpoint, it's an opportunity for me to give back. Although I was born in the United States, I was raised as an African also. I eat the food. My mom made the food. I still eat the food
Fu-
now. I go back and visit family. So to be able to go back and visit family and for them to meet my wife and my kids and, for me to meet my cousins and nephews and grandparents, all of my family's in Africa. It's a very small family that's in the United States. So for me to be able to go back and see them and then say, hey guys, I got a jet because I got to go to this hospital down the street or provide care, for them is one of the biggest. It's a dream come true for me, right? I
Mm.
really feel like I'm doing, work that I was put here to do. And oftentimes, and I tell this to people, oftentimes like whatever you feel like doing or whatever you want to do, it's not gonna like come to you like like you're not going to just see it. It's not going to be very apparent, right?
Mhm.
Oftentimes people who say that they're doing really great work oftentimes like step into it or stumble into it. I was actually brought into this by my wife. She was my girlfriend at the time, but she trained under those two people, Dr. Akins and Dr. Ayers at her hospital, and they were doing it. And then I was like, oh, what are you going over to Ghana to do? She's like, I'm going to do X, Y, and Z. I was like, wait, what? You need to get me involved in this. First of all, that's my country, right?
What's up?
You need
What's
to get
up?
me involved in this, and then I just never thought that it would be so rewarding, right? So,
Mm.
I oftentimes tell people that, you never know, like, I always tell people, just try something different, do something that makes you uncomfortable because you never
Right.
know. Like it may end up being the work that you find most fulfilling. So,
That's beautiful. And I've only been to Ghana, was it twice? Yeah, twice. And so one thing I gotta say is when you come back, it really makes you appreciate the small stuff. I have a lot of family in not quite rural settings, but it's third world, right? So
mhm.
you don't have a hot shower. There's no washing machine. There's no laundry machine. It's real. And yeah, it makes you appreciate how fortunate we are living in North America. But that feeling though of when you see your cousins, your family. Oh my God. Like literally my situation is exactly the same. And got a few cousins in Canada, but almost exclusively in Ghana. And
Yes.
just seeing that family honestly, it's magical. It's incredible feeling.
It is. It is.
I love
It's
it.
very,
I
I
love
can
it.
imagine you just feel like you're home, right? Like
Yeah.
when you get off at Kotoka Airport and now, can you believe now the airport, they have a terminal now where you can actually go straight from the airplane straight into a terminal. But
Yeah.
you remember going down the stairs when you get out of the
Oh
when
yeah.
it's just that smell
That
that's like,
smell, that
wow,
air.
I'm home.
Oh my
That air,
goodness.
that humidity, and
Oh
or when you
yes.
drive, when you're flying, and if you're able to pay attention, guys, or women, if you're listening, like when you fly into Ghana, like, and you come right off the coast, you just see just this red clay, and then you land. It's just like amazing. It's just so different.
It's so different. And the people, it's beautiful. One of the things that I got to experience last time I went was actually, I've been 3 times. What I'm saying it was a funeral for the Ashanti Henny, or the Ashanti
That's
King's sister,
okay.
and you just saw all this royalty in Kumasi Center going off, drum beats, people singing. It was like, I am home, man. It was incredible. I wish I took a video of it. I was just too into it to wanted to take to pause and take out the camera. But oh my goodness,
Yeah.
well, I'm digressing. Listen, I just want to thank you so much for doing this. I know as a trauma surgeon, as a podcaster, your schedule's crazy. Having a 3-month-old at home, by the way, your life is going to be crazy for the next year, especially going from 1 to 2. But you'll be fine.
Yeah.
I really appreciate you coming on. You do amazing stuff, and it truly is an honor to have you on the show.
Hey, thank you very much, Dr. Quadro. Thank you for having me on the show. I've listened to your show. You're doing amazing stuff too, and keep at it, man. And for the listeners, man, please continue to share, this podcast with other people. And there's sometimes we may have uncomfortable conversations, but it's the things that need to occur, and these all come from a good place. So I want to once again thank you for letting me come on your platform and share my thoughts of the U.S. system and some of my upbringing. And I hope you continue this, and I hope the listeners continue to share this episode or share your podcast with other people to help it grow.
Absolutely. And other docs too. We're probably going to plug this in the both the intro and outro. But yeah, docs outside the box. You love it, baby. Yeah.
Yeah.
So thanks so much.
Yo, tell me that wasn't proper, yo. Thanks so much for listening in. If you loved the episode, please leave a 5-star rating with the show. Follow us on Twitter, Instagram, YouTube at Quadcast. Leave any comments at quadcast99@gmail.com. Shout out to our fans in Lacombe, Alberta. We love you. Follow Nii's podcast at Docs Outside the Box. Once again, we'll have that link in the show notes. And everybody, thanks for listening, and stay safe.